Hi. Good morning. This is a public service announcement from the foundation. So, each week we try to bring a, trial that's up and running at the foundation just to make you more aware of it. And certainly if you could contribute to enrollment, that would be even better. So just to make you aware of some of the things going on. So this one is a trial I'm involved in called CONCERT-HF. It's sponsored and funded by the NIH and the Cardiovascular Cell Therapy Research Network. And we've done for many years a lot of stem cell trials. This is the first trial in the world to give two stem cells together with the goal that there will be a synergy above and beyond giving either one separately. These two cell types are mesenchymal stem cells derived from bone marrow, and then c-kit cardiac stem cells derived from the patient's heart via cardiac biopsy. And this is for patients with ischemic cardiomyopathy with ejection fraction less than 40% by CMRI, and must have a certain amount of scar greater than 5% of the LV volume, and pass a cardiopulmonary stress test. So we're about 2/3 of the way enrollment with this trial, so I imagine we hope to get it done maybe by the fall. But occasionally, when you go on outreach, you'll come across patients like this that really never been maybe referred to our heart failure clinic. But certainly this is a potential option for some of these patients, particularly if they're not, you don't see an LVAD or transplant on the horizon. But I think there's a lot of patients out there like this that meet the criteria. So I just want you to keep us in mind when you see these patients. Now I'll turn it over to Kevin to introduce our speaker.
Good morning. My pleasure this morning to introduce David Miranda, one of our senior cardiology fellows. This will be his last grand round, extra grand rounds he volunteered to give. David has done a great job as a fellow. He's a hardworking fellow, a really fine physician. I'm personally going to miss him. He's the only guy in any aspect of my life that calls me boss. But he's going to go to Methodist DeBakey to do a special year of training in heart failure transplant. And then we'll be joining our former fellows, Jamie Pelzo and Ben Johnson in St. Cloud. So my pleasure to introduce David Miranda.
Thank you, Dr. Harris, for that kind of introduction. As a fellow, you don't volunteer, you just say yes. So that's what happened. So today, what I'm going to talk, the title is the Vasodilator Strategies for the Treatment of Cardiogenic Shock. So what we did is, when I started fellowship in April of 2015, we developed a vasodilator protocol to wean patients off nitrite in the ICU. So I'm going to specifically talk about which patients we're talking about, and we're going to walk a little bit throughout what we found and the results of this protocol after 3 years that we looked into. So no disclosures. I'm going to start right ahead with the case. So this is we're going to present a 66-year-old guy, and he has this history of ischemic cardiomyopathy. So this patient presents to clinic. So we see him, he has 2 weeks of progressive shortness of breath, he has lower extremity edema, and he has increased abdominal girth. So his blood pressure is a little bit in the low side, 95/77. It's pretty typical for the advanced heart failure patient that we see in clinic. So his heart rate is 92. And then his pertinent findings on exam is that he had elevated neck veins, he has bilateral crackles, so systolic murmur, and he has lower extremity edema with some cool extremities. So bottom line is that this patient comes to clinic, he's in decompensated heart failure, and we see some evidence of cardiogenic shock here on exam. So we do the echocardiogram, and we can see the dilated ventricle. And here's the echocardiogram. So the first two pictures up, not great images, but we can see a very dilated left ventricle, low EF. And then down here with contrast, just confirm what we were thinking, that this is a pelvic systolic dysfunction, is diffuse, not great contraction there. So next step that we do is take the patient to the cath lab. So the pertinent things that I want to talk about here is that the patient had bilateral high filling pressures. So a right atrial pressure of 20 millimeters of mercury and a wedge of 36. I was recently at ISHLT, and Dr. Colombo, one of the heart failures, says that a CVP more than 20 is like a systemic blood pressure of 300 for the right ventricle. So that really stuck in my mind that this is clearly high filling pressures in the right ventricle. The other pertinent thing is that his cardiac index is low, so that meets criteria for cardiogenic shock with a cardiac index of 1.8. Important to see also that the SVR is high. So this is a patient with low cardiac output and vasoconstriction. So what's next? So this patient is admitted to the ICU, the CCU here, and the PA catheter is left in. So he started on furosemide drip, he started on sodium nitroprusside, and we held the beta blocker and the ACE inhibitor that he was prior to admission. So here I want to walk you guys through the CCU course. So let's focus first on this first line here. So at time 0 in the cath lab, we already know the pressures. So the dose of nitrite at that time is 0 as well. So this is in the cath lab. So after 8 hours of being in the ICU and at a dose of 1.5 mics per kg per minute, we have that the CVP already dropped 4 points. The wedge is already dropping as well, and then the cardiac index is improving. So this is a little bit of how we start hemodynamically reconstituting this patient. So 12 hours and 18 hours after admission to the ICU, we can see in the right column over there, the dose of nitrite is up to 2.5. And the asterisk means that at this point, we have to start thinking about how we're going to get rid of this IV medication. So at 12 hours from admission, we can see that he has a CVP of 10 and a wedge of 18 and a cardiac index of 2.8. So technically at this point, he is hemodynamically reconstituted and he's in a good spot. I mean, clearly there's more progress that we need to do. He needs more diuresis. And this is what we accomplished at 18 hours. So at 18 hours, excuse me? How much is the diuresis? So, well, depends. Every patient depends. But in theory, what we achieve is at least 1 liter per hour, per shift, sorry. So varies on the patient, but that's what we achieve for. Okay. So in red here, what I have is at 22 hours from admission, and the dose of nitrite is at 1, and the parameters are pretty good as well. So what I want to show here is that this is what we do with IV medication, and the question is how we transition these patients to oral medications without stopping what we already did from a hemodynamic standpoint. So the objectives of my talk today will be review the treatment of acute decompensated heart failure. Specifically, we're going to talk about acute heart failure management and vasodilators only. Acute heart failure management includes diuretics and inotropes in some circumstances, but we're going to focus on vasodilators right now. We're going to talk about the sodium nitroprusside for the cardiogenic shock, and we're going to talk about the oral vasodilator protocol that we developed and the results that we got after 3 years of having the protocol at the ICU. So the clinical characteristics of acute decompensated heart failure, as was shown by this 3 trials that include multiple patients, is that we have a lot of comorbidities. So these patients have hypertension, they have coronary disease, diabetes, a lot of them have atrial fibrillation. But the majority of patients, as we can see here, are admitted with hypertension or they're normotensive. The minority of patients are in cardiogenic shock or hypertensive. So the distribution of EF among the patients that are hospitalized varies, but on today's talk, we're going to focus specifically on patients that have an EF of less than 35%. So throughout, the distribution is very uneven, but this is what we're going to focus on today. So outcomes during and after acute heart failure hospitalization. So we know that obviously it's expensive, not good for the patient. And for example, at the 1 year mark here, and we see here the same patient in green and then in red, every admission that they have a higher mortality. Every time they get admitted, they have higher mortality. So the mean length of stay for a patient is 5 days here in the U.S. There's 20% of patients that are readmitted after 30 days. And there's a 12% mortality of the patients that are admitted with heart failure at 30 days. Now, the hemodynamic profiles of acute decompensated heart failure, this is what we try to do every day in the ICU. So we try to move patients from the warm and wet stage they are to the warm and dry, okay? And we achieve that with diuretics and ultrafiltration, that is not very used nowadays. And then we achieve that with vasodilators as well. The other strategy that we use is the patients that are cold and wet here in the right corner. And we try them to move to a warm and wet state and then to a warm and dry state. And this is what we try to do in the ICU. So what are the goals for these for patients with acute decompensated heart failure? We need to improve symptoms. We need to optimize volume status, identify the etiology of the acute decompensation, and then identify the precipitant factors that were associated with this hospitalization, and optimize the chronic drug and device therapy that they're with. So as I said, we're going to focus specifically on the vasodilators today. The guidelines are pretty specific in vasodilators that patients with symptomatic hypotension, we need to use IV nitroglycerin, nitroprusside as an adjunctive therapy for the management of these patients. This is given a class 2B and a level of evidence A in the guide. Here I put a table to compare the different strategies or the 3 different medications that we have to treat acute decompensated heart failure. So we can see that the hemodynamic effect is pretty standard among the 3 medications, and we need to titrate the nitroprusside and the nitroglycerin. Also, it's important to know that the nitroprusside can have some toxicities. So these medications, bottom line is that decrease preload, they decrease afterload, and decrease the oxygen demand and increase the oxygen supply to the myocardium. Okay, so at our ICU here at MHI, the Advanced Heart Failure team, it's important to know that all these patients that we admit, we try to have Swan-guided therapy. Okay, this will give us hemodynamic feedback every 4 to 6 hours and allow us for titration of this medication. So what is the importance of this? This will give us, the end result of this is that in less than 24 hours, we can efficiently and hemodynamic reconstitute these patients when they're admitted with cardiogenic shock. So what are the hemodynamic targets that we try to achieve with these patients? We want pulmonary capillary wedge pressure of less than 18, a CVP less than 8, cardiac index of more than 2.2, and a mean arterial pressure between 65 and 75 millimeters of mercury. Okay? So if we go back to our patient here, this is what we achieve at hour number 12. Okay, so at 12 hours after admitted to the hospital, this patient achieved a good CVP, but they're a very high dose of nitrite. Okay, so we know from the BMAC trial that patients, when we put them on vasodilators, we decrease the wedge pressure, and we achieve this quickly, and this is effective. Also, this is associated with doses, okay, as we can see here. So the higher the dose of the vasodilator, the lower the pulmonary capillary wedge pressure. And the problem with this is that this gets to a plateau, and at some point, the patients develop tolerance, and this cannot be achieved at some point. Some investigators have proposed that adding hydroxyl to these medications, as we can see in this graph, if we use nitroglycerin alone or nitroglycerin associated with hydroxyl, these can reduce the tolerance of these medications. Patients with low EF have a better, have improved survival when they are managed with vasodilators. As I said, specifically with sodium nitroprusside, these can have toxicity, and the cyanide molecules have been associated with this. So what are the limitations of the nitroprusside? Okay, so these medications, as I said, they can develop resistance, and the patient develop tolerance over time. We don't have long-term data, either efficacy or mortality. It's only available IV, and it's really expensive. This was recently published in the New England Journal of Medicine, and is the pricing of the nitroprusside drug in the country over time. So as we can see here in 2012, the pricing of a 50 milligram vial of nitroprusside was $27. We're going to focus on nitroprusside. In December of 2015, the price was $800. Okay, so it has been increasing the price. What about Abbott Northwestern? Well, it depends. Okay, so it depends on the patient weight, depends on the infusion rate, and also the dynamic pricing of the drug over the last 5 years. Okay, other healthcare cost considerations are the nursing time, the reason that the patient is in the ICU, and that they need a right heart cath for monitoring. Okay, so for example here, I want to show here that an 80 kilogram patient running at 2.5 mics per kg per minute, the estimated drug in 2013 was $250. In 2014 is $4,700. Matt gave me this information for Elena. Excuse me? Okay. Okay. So this is what we developed the protocol. So this is the rationale for the protocol. We want to facilitate the transition from IV medications to oral. We want to decrease the length of stay in the ICU. We want to decrease the overall use of nitrite, avoiding toxicity, and we want to decrease the cost. So these were the reasons that we developed the protocol. Okay, so the objectives. So we want to assess and describe the hemodynamic response and tolerance to an aggressive oral vasodilation up-titration after IV therapy in patients with acute decompensated heart failure. So our secondary objectives were decrease the length of stay in the ICU, decrease the 30-day readmission rate, and decrease the overall use of nitroprusside, avoiding toxicity, and to see if this aggressive up-titration will result in higher outpatient doses of the vasodilators these patients were. So these are the methods that we use, the inclusion criteria. So patients admitted to the ICU, they have a PA catheter. They receive the IV vasodilator agent, obviously. They have a primary diagnosis of acute decompensated heart failure between times of January of 2013 and December of 2017. They were more than 18 years old and an EF of less than 35%. So important thing here is that the protocol was developed in April of 2015, but I'm going to explain soon the reason that we picked, we went back to January of 2013 to evaluate these patients. distribution of patients here. So I'm going to put your attention to the right side of the screen here. So the protocol group first. So between, as I said, we developed it in April of 2015, and all the way to, and we stopped the period in December of 2017. So that gave us a total of 140 patients. After we assessed for ICU admissions, EF less than 35%, we got a total of 57 patients. So then after this was developed, we have two control groups. We have a control group after the protocol established between the same time period, April of 2015 to December of 2017, and we got 691 patients there. And then after analyzing the patients only admitted to the ICU, an EF less than 35%, we got a total of 155 admission patients. But at the same time, we want to compare these patients to a pre-control group before the protocol was established. So at that, we had a total of 600 patients there. After reviewing the patients with ICU admissions, EF of less than 35%, we got to a total of 92 patients for a total cohort of 307 patients, and that was our study cohort. So here's an example of the guideline that is given to the nurse for the protocol, specifically for Captopril. We have for both Captopril and hydroxynitrate. So, for example, if a patient is on 2.5 mics per kg per minute of sodium nitroprusside, and we want to start weaning these medications because we achieve hemodynamic targets, we give a dose of the medication, let's say Captopril, in this example, 6.25, and the MAP is acceptable. If this is accomplished, we double the dose of the Captopril, and then we wean the nitroprusside by 0.2 mics per kg per minute, having the same, if we have a good MAP. If this is not achieved, MD is called, and then we have to schedule the doses. And this is progressive, and the doses are escalated and doubled. So this is the example with Captopril, and this is the example that we have with hydroxynitrate. And we have a print paper copy that we give to the nurses. And to the left of the screen, we see the time. And we do this, we try to do it every 2 hours, and this is written and this is given during rounds. So the hydroxynitrate dose is to the discretion of the physician, but we usually do 10 and 15. So 10 of hydroxynitrate, 15 to 20 of the isodel. So the same concept, if we have good maps after 2 hours, we assess every 15 minutes, but if we have a good map in here with the time, we go down on 0.2 mics per kg per minute of the sodium nitroprusside. Okay, so now the patient characteristics of our study. So we had a total population, as I said, of 307 patients. Before the protocol, we had 92 patients for 30%. After the protocol, we had 215 for 70% of the patients. Off the protocol, from these 215 patients that were after the protocol, we had 157 off protocol and only 58 on the protocol. Okay, so pretty much is a majority male population, and the age is around 60. That is the mean age that we have for the patients that were before and after the protocol with no difference. The patients after the protocol, pretty similar characteristics. Majority were male, and then an average rate age of in the 60s. This is a sick population. The mean EF of the population is around 20%, and the majority, 2/3 of the patients had coronary artery disease. So pretty typical patients that we see in the ICU. Same after the protocol, patients that were off and on the protocol, 20% the EF, and majority had coronary artery disease, 2/3 of them. Medications. What I want to show here is that from all this list of medications, the important thing is that there was no difference among the groups with medications. So most of them were in guideline medical therapy. So very, very appropriate therapy for coronary disease. The majority were in aspirin and statin. Most of the patients, as I said, were in guideline medical therapy for heart failure. And important to know that patients were sick. We had almost 40% of the patients were on intravenous inotrope at the time of admission. So we look also at the hemodynamics of these patients when they were admitted and then at the onset of the protocol. So the way we look at that is the map, the first map that we got on admission to the hospital, and then the second map is onset of the protocol. So here we see some difference, but I mean, this is what we're trying to achieve. We're giving IV vasodilators, we're trying to lower the blood pressure. For CVP, there was no difference, and then for wedge, there was no difference. But the point is that we achieved decrement on all these parameters among our population. We did a multivariate analysis to see if there was any difference on patients on protocol versus off protocol, or when we had a protocol, after we started the protocol, on the patients that were on and the ones that were not. And we put in the model all these 7 variables that are the ones that were used in a similar study that we had, that we referenced, the only prior study that did a similar thing. And the bottom line is that there's no difference among our groups in this multivariate analysis. So now I want to show the results that we have for the specific objectives that we were looking for. So the ICU length of stay for the total population was 3 days. The total nitrate use was 71 hours, and the readmission rate was small. It was 22% for 63 patients. This is at 30 days. So before and after the protocol, we don't see any difference for the ICU length of stay. So both populations had a length of stay 3.8 days versus 2.8 with no statistically significant. The nitrate hours, after the protocol, we had less nitrate hours, but no statistically significant. And then readmission rate, the numbers are really small to say something significant, but there was no difference. Now, what about the patients that were off and on the protocol? ICU length of stay, there was no difference either. And for some reason, we had more nitrate use on the patients that were on the protocol. Okay. Readmission rate, also small numbers, so no significance there either. Why do I think this happened? I think this brings us to the point of the underutilization of the protocol. So here, this is the percentage of patients that were eligible for our inclusion criteria admitted to the ICU. So all our inclusion criteria for our study, and this is to the patients that were admitted to the ICU. So for example, look at in November, December, January, and February of the end of 2011 and the beginning of 2012, there's 75% use among providers, but then it drops to 0 in 2 months. So, and I'm going to talk about why do I think this happened, but there was significant, we see this yo-yo effect with significant variability among the providers. So the mean use was 28% per month. So now, why do I think it didn't significantly impact this protocol? I think sometimes when I'm rounding, I see some of the attendings, and I've been asking. So sometimes say the patient is 2 tens for a rapid oral dose escalation. they can have really low blood pressure, and if we are very aggressive, yes, Dr. Abdehadi.
Problem is something, but why should we even use a protocol? When you showed the data, you didn't convince anybody that it helped.
So before we talk about underutilization, I probably missed something, but did you show us that the protocol helped?
To say whether or not it works. That's not, you shouldn't use that statistical significance to say anything about the protocol. We don't know if it works.
That's correct. So it's not, so you're saying if you didn't get a chance.
Yeah, if
Got
it's
it.
going to work, you got to use it enough to have an impact. No.
It's also, I would argue, getting off nitrite faster may not be the only reason to use this protocol. Coming off nitrite faster may not be the only reason to use this, but I don't want to hijack your talk. So.
We afterward we can have more discussion. So so I think, to my point, I'm going to get that we don't show that it is really significant, the protocol, and part of it is because we are underutilizing the protocol. So and I'm going to get to that. So I think some people say that if we give high dose of oral vasodilators, we tank the blood pressure, and this is not easily titratable. So this can create some issues in the ICU. Sometimes the protocol is not used because the patients are in a very low dose of sodium nitroprusside, so it is easy to titrate up, and we don't have to use the protocol. Sometimes patients have angiotensin receptor antagonists prior to admission, and we don't have a specific protocol for this sort of medications. And then when Matt or other pharmacists are not around, sometimes some people forget about the protocol if they're not in round. Okay, so also it's important to say that acute heart failure is a very complex syndrome. Okay, it presents a very broad spectrum of conditions that just a single disease. So I think we have to continue education among providers and nursing staff about the safety, about how expensive the nitrate use, and strategies to wean the protocol, to wean vasodilators. I think there's a lot of heterogeneous use by providers. Some providers really like the protocol, some of them don't. I think the transition is not clear. When I know we have guidelines when the wedge is this, when the CVP is this, and we got a good map with good cardiac index, that's when we start thinking about weaning. But I've seen some variability to either start a protocol at a very high dose nitrite or when we're already escalating down. And then I think because, to my point about the acute heart failure is very complex, we cannot say that a single therapy will work for all this complex syndrome. How do I think we should, or what do I think about this protocol itself? I think the protocol addresses only a small part of the weaning part of nitrite. I mean, these patients, sometimes they be in a nitrite for a long time, and we are using the protocol only as the last part to wean these patients. Sometimes if we don't use a protocol, the provider discretion is better. Let's say we have a provider that wants to give a high dose to start of the Captopril. I want to do 25 and then go down from there if that doesn't work. So that also, I think it's important to note. As I said before, EC weans, they usually don't use a protocol. So if the nitrate is a really low dose and the patient is not very congested, I think this introduces some bias because the protocol is reserved only for very high doses weans that these patients are thicker or they have higher or they have higher pressures than we started with. So the time has been longer. I think we included execution errors. So for example, where at the beginning of the protocol, obviously as anything, there's some curve, some learning curve, and we included in our study some parts where there were nursing errors. Also, I've seen that the providers have aborted the protocol, and these were included in the protocol arm. So these two. So I think to conclude, I think vasodilators are very important in the treatment of acute heart failure therapy. They're also very important in the management of chronic heart failure therapy. And I think we have to, going forward here, I think the strategies to increase the utilization of the protocol will be education among the providers. We should be aware of the cost of being in the ICU, of the medications that we use, and developing some protocols for optimization of care is important. I want to give special thanks to Dr. Bennett and Dr. Bradley that were my mentors during this project. Matt, that helped me a lot with the pharmacy part, all the MHI advanced heart failure section, the physicians and APPs. Larissa from the foundation, Chelsea from the Alina Performance Resources, the MHI Center for Healthcare Delivery Innovation, and the foundation in this 3-year project. So thank you.
David, great talk. I was just wondering, how did you initially come up with the weaning protocol? Was that adopted from some other center that had been using that, like as in how to increase the Captopril, like, or was it just formulated here based on what people?
Maybe Dr. Bennett wants to answer that.
Nice job, David. So the weaning protocol was started here, and it was basically adopted from a protocol, a very similar protocol used at the Cleveland Clinic. We made some modifications based on the specific setup of our ICU, and but it's largely based on one that was used at the Cleveland Clinic, or that is used at the Cleveland Clinic.
Yeah, nice talk. But just to go more on that, has there been any, heart failure readmissions are associated with mortality? Has there been any evidence, probably not here with a small sample size, but in Cleveland, that you're reducing readmission with the vasodilator protocols, and does that portend any survival advantage?
So they have an article about the protocol. It's the only article that is out there, and it's out of Cleveland Clinic. And they didn't reduce readmission. They just described the protocol, and they described it was safe, and they described how to use it. But they didn't talk about readmission.
They didn't look at it, you mean?
No, and they have also a small sample.
A couple questions. First for Matt, why is nitroprusside so expensive?
So one of the poster child events for going from a multi-manufacturer down to a single manufacturer. It's part of a lot of the press around medications that were generic but only single manufacturer, the price skyrocketing. So it went from about $40 a vial to almost $900 a vial because Valiant Pharmaceuticals was the only manufacturer for a period of time. Thankfully, there's some people returning to market now. So we're hoping that it continues to fall back down again.
So, I mean, it seems like it's a worthy goal to do this. Why, or what would be the next steps to enhance buy-in amongst the physicians and providers taking care of these patients, and what are you going to do next?
So I think wide education is very important because I think it hasn't been described. People were using it, I will say very inconsistently. So I think that is one of the main things that didn't happen. And that happened, that sometimes you see like 75% use in a month and 0. And then I think also important is to look further. I mean, see patients, see more patients, see if it really works in a longer period of time.
Yeah, so I agree. I think that it's, there are definitely some good reasons why a protocol to ease the transition off of nipride would be helpful. In the ICU, you can achieve this hemodynamic reconstitution very quickly, but it's really not reflective of what these patients will experience when they leave the ICU, when they leave the hospital. And easing that transition is sometimes the hardest part about managing these patients in a Swan guided method. I think in terms of the protocol, it's really tough to make any conclusions about it now. Less than a third of the patients that we that were eligible for it actually benefited from the use of the protocol. So I think as a group we have 6 heart failure cardiologists who had access to the protocol and are largely the cohort of physicians that would be using it. So the goal, one of the most immediate next steps would be to increase the use by our group.
Really nice talk. I just want to add to that comment about what to do next. I think this is a classic quality improvement cycle of plan, do, study, act. You know, you planned out the idea that nitroprusside use is important to address in terms of length of stay in the ICU and the cost of the medication and optimizing patient hemodynamics quickly. You did. You put into place a protocol, you studied it, and you've now identified the problems.
Yeah.
There's underutilization. I think there are a number of reasons oftentimes things are underutilized. If we don't make it the easiest thing to do, people won't do it. So the fact that there's an additional thing that you have to print out, you have to remember to do that. If this was embedded into the order set for nitroprusside, my guess is that would help overcome some of the barriers in use. The other tension is the ideal in terms of a study that then you can have understanding of the impact on patients individually versus the impact for a system. So clearly, we excluded probably 2/3 of the patients because they didn't meet kind of this homogeneous patient population we wanted to understand. But there's probably some utility to expanding it in terms of the use of the effect of our system. I think there's both the nice part of the patients with a reduced ejection fraction, so you can understand from an individual patient standpoint, but from a hospital system, being more broad might have a bigger impact for the hospital system. But obviously there's an opportunity here. It's a matter of if there are folks engaged and want to move forward, thinking about what were the barriers, how do we address those barriers, planning for it, and then going through another cycle. And I think now we've set up a situation where we can, as opposed to the number of years that it took to get to this point, we can now do that on a more rapid iterative cycle.
Okay.
A little bit, first of all, great talk. But related to what Steve just said, so why was 35% the inclusion criteria, not a, since you do a Swan guided method, why is not a Swan hemodynamic the inclusion criteria? Because, I mean, there's a lot of patients who might have an EF of 42%, right, and still have this.
We wanted to see it for advanced heart failure or cardiogenic shock patients. That's why we did it. So we have the data for all the patients. But in this specifically part of the study, we wanted to see the patients that had low EF.
So in data for all the patients is different?
No, I don't.
Okay,
I don't
not
know.
analyzed. Okay.
Yeah, we don't know it because we know it's only different.
And the other thing, just slightly related, not really, maybe you don't have the answer, maybe Steve has. So since we have all these data, how much money do we lose on patients who have to go through the nitroprusside because we don't adapt to oral medications, plus then the readmission of 22 or 23%? How much money do we lose per patient in this kind of population in the healthcare system?
Yeah, so first of all, our readmissions aren't at a point that we would be penalized, so we don't lose any money in that way. And second of all, we don't know the opportunity yet because we don't know the effect size that we might expect to see with reduction of nitroprusside use, so we don't know where we can get to. So to kind of say that this should be our target is a little hard to say at this point.
Thank you, David. This is a really important topic. I'm glad you took the time to study this and look at this. I think I'm a fan of the protocol. I don't know if I'm a high utilizer or not, but I like the concept of it. But there, I think a couple of things I would be cautious about. Number one, I think the people that get put on it versus not, there's a potential for a significant selection bias there, and you've obviously tried to accommodate that. But I think going forward, that would be something that I think would be important, would be to randomize to this or not. I think there are some benefits to it beyond the get off the nipride faster in terms of consistency, in terms of getting people on higher doses of oral vasodilators. But then there's also a backside of, even if it had convincingly shown that you decreased ICU length of stay, what we often see when we sort of ignore pharmacokinetics to uptitrate rapidly is then a day or two later, then they're hypotensive on the oral meds as the kinetics catch up and you're on a higher dose, and then you have to back it off. And so it may shorten the nipride duration and the ICU duration. It may lengthen the hospital duration. For example, we looked a little, it was a year and a half ago at some of the diuretic protocols, thinking, this obviously would have a lot more applicability. Can we use rapid titration diuretic protocols to try to decrease length of stay? Because obviously there's persistent heat from the hospital on, please, shorten length of stay. Yeah. And it did turn out, at least from the published studies, that, which there aren't many, that protocol actually increased the length of stay. And so sometimes these protocols have unintended consequences. So I think that also highlights that it's important for us to not just accept that this is better. And so I really congratulate you for studying this.
I think, Peter, you probably answered a lot of the things I was going to ask, because I don't think the goal from anything is just to use the protocol, although protocols are good if they want to standardize care because there's a lot of variation and so forth. So protocols are good, but I'm not sure that I fully understand what's the goal from the protocol yet. Is it to decrease how much you use nitroprusside, or decrease length of stay in the ICU? Or so what I'm trying to get at is, if you intended to use it for everybody, what would have been your control? Was it patients before the protocol, or are you going to randomize, like Peter said, and then show some value? It's extremely difficult to have physicians use a protocol, even when there is clear data. I remember the AFib protocol and the pop-up, there are studies done and so forth, and it was extremely difficult until we started to show that there's value, then more and more people, and now it became more of a routine. So for this one, people say, well, I do whatever I want, and I have lower length of use of protocol, and I don't know, why do you want me to use the protocol other than the 90% is better than 30% use? So if you explain it better, is what's the goal? And we need to use the protocol to see if there's goal or not, and it probably becomes more sellable, at least.
So the way nitrite was weaned, I think, before, and then what it seems is very variable, even without a protocol. So I think what we try to do is try to have it done in a more consistent way, and that was part of the reason why it was developed.
So I was just going to comment on that comment about randomization. So the selection bias is real, which is why you wouldn't typically do an on versus off comparison in the same time period. So the primary analysis was intended to be pre-post accounting for the slope and change of duration over time, because of the reason you bring up. I don't think you want to do a randomized trial, because then you actually make this a research study as opposed to a quality improvement opportunity. So I think that you keep it as a group, is there something that we can point to that we say this is the rationale for thinking about doing this? This is the patient population we're really going to focus on, and try and see what your goals are. To the point of unintended consequences, those are really important. To use a corollary example, we had identified that there was increasing use of sternal plates for closure after CT surgery, and we'd done some work to suggest that what had been seen in the randomized controlled trials in our own population we weren't seeing. But our surgeon said, well, you're not thinking about other potential unintended consequences about pain, delayed sternal non-union. And so that having those conversations and becoming aware of those gives you the opportunity to look for those outcomes. So again, in the same way, having those conversations, you can look for patients who end up on the floor and then readmitted back to the ICU because they're hypotensive or other things. So those are important components to keep in mind as you go through another cycle of this.
Can you just get rid of nitroprusside, or is it so good? I mean,
That's a good question, right?
Well, no, it's a very good question. We've talked about using, for example, nicardipine. The problem to some level is that there really isn't data on nicardipine, for example, in acute decompensated heart failure. Nitroglycerin has a lot of problems. People get tachyphylaxis very quickly. You need very high doses, 200 mics. And so, I think the other part of it is that most of us here now sort of grew up in the era where it was cheap. And so we were always patting ourselves on the back of, look, we're using this cheap drug that's so good at making people better, and then the drug went and got expensive on us. So I think we have experience with it. I think there is, some of the early heart failure physiology studies, is one Jay Cohn published. It's amazing. It was 18 patients. It was in the New England Journal, basically showing the use of nipride for heart failure. And the data from the 2008 paper that Wilfred Mullins did, where they looked at people that were treated with nipride versus not, had a substantial improvement on in-hospital mortality. And so that really is the evidence-based vasodilator for reduced EF heart failure, which gets to your earlier point of, well, what about the EF of 40% people? I would be much more reluctant to use it in them because it's expensive and there's not data, whereas the dilated ventricles, EF of 20%, SVR of 2,500, this drug's like magic. I mean, it works really well. We talked about trying to do a prospective study of that versus nicardipine, but, to Steve's point, to declare this a prospective randomized research study all of a sudden becomes an enormous hassle. Then you got to figure out who's going to pay for it. There's little to no incentive to use a cheaper drug when Martin Shkreli is making money hand over fist from Nipride. Well, not anymore. So I would love to be able to use another drug or have a competitor, but I'm hoping that, to Matt's point, that as more manufacturers come out, it'll become cheaper again, and then the cost won't be so much of a driver.
So where would you go from here? I guess I was a little surprised that within your section there obviously is variability. If these are all advanced heart failure patients,
Yep.
And so there's not consensus even in you. So how do you make this? And maybe this is for Steve as well too. How do you come to have a meeting? You say let's just do it, or obviously that didn't happen.
I don't know. I mean,
because it's not going to go anywhere if you have underutilization.
But I think a lot of this gets into the patient characteristics of who uses it when. And I see this when there are times when some of the other heart failure docs will start it earlier than I would, where I feel like they still need some more decongestion. I don't think either of us are wrong. It's more of a style point. But I think that's a good question. I'd be curious to hear what Mosey thinks about it.
It's a great question. I mean, it's a challenge because how can we convince people to use it? I mean, do we mandate the use of this protocol? You can't do that. So it's and we all have different, there are nuances and styles of practicing in the ICU. So I think that's a challenge, and I think as a section we'll have to continue that discussion. I don't have a good answer for that.
Can we make it ourselves? I'm just asking. Do you have some say on that in your business? How difficult is it to make like an IV drug? Is it so difficult that you just borrow that? I mean, it's impossible to do it, and you could never pick something like this up. Like if there's people that always want to fool us with more expensive drugs. I mean, is it? No, I'm serious now. I'm actually serious. In Germany, you can.
Mario, there's a consortium of hospitals that have banded together. I read about this, I think, in the New York Times or Wall Street Journal, something probably 6 months ago. And correct me if I have this wrong, Matt. The big hospitals like Intermountain and like MD Anderson and a bunch of places that basically said, we're going to start a drug company and we're going to start making some of these super cheap drugs. They wouldn't say what drugs they're going to make because then they're worried that then the big dogs will come in and try and undercut them. But there's been some interest in that. I don't know, Matt, if you want to add to that. I'm sure you know more than I do.
No, that's more or less the gist of it. They've been kind of coy, I think, about what the specifics are around all of it. But I think the regulatory aspect, and I think that's why big dogs in a big group, the actual manufacturing probably wouldn't be that tough. But the regulations, FDA regulations around making sure that they're sterile and all that, I mean, with all our drug shortage issues we have now and the cost issues, sometimes like from a drug shortage standpoint, it's something simply as the company didn't submit their FDA paperwork on time, a day late. And then now we're short on a drug because they have to halt manufacturing, stop it for 3 months, and it puts us behind the 8 ball. So you can just imagine the hassle that it takes to make sure we meet those regulations, which are for the benefit of the patient, but challenging nonetheless. Just to put this all in context real quick about the drug cost, I met with Dr. Ekman. It was probably September 2015 when this pricing really ramped up. And to put it in context, in September 2015, it would have been cost-effective to use Nasiratide, Natracor, over Nitroprusside. And then on my kind of high-level analysis, we would have saved our hospital $1 million if we used straight Nasiratide, the drug that we've tried to avoid because we don't think it's that great and it's super expensive. It would have been that much more cost-effective.
I'll
So one of the things we did in the cath lab, I don't think Craig is here, but you know about this, is we had a high-risk bleeding score we started utilizing in 2009, where we didn't mandate the use of bivalrudin for those who are at high risk and with PCI, but we certainly set goals, which yearly goals, to do that for the group, our section goals, which we're not doing anymore, so it may not be as useful. We certainly did get utilization over 70% eventually. Just using the protocol was a goal, period. And then we did have some interesting trends towards certainly saving around $750,000. I don't know if you were around at that time, Matt. Just by decreasing the length of stay, by decreasing bleeding, by the use of bivalrudin. What we eventually learned is that we were using too much. We historically have always used too much heparin, so we don't use that protocol as much anymore. But it was very eye-opening that just by intervening on bleeding risk did shorten the length of stay and did equate to cost savings in the hospital. I don't know if you can construct something like that with this in our current environment.
Yeah, I think it also becomes a question of where do we want to target our energy and what do we want to improve the quality of?
We have plenty of data leading up to ours.
Yeah. Yeah. Well, and I think this is really critical too, because we may find maybe this doesn't shorten length of stay. I mean, I like it because I think we do titrate faster than if you have to wait to come by every 3 hours, and by the time you put in a new order, it percolates through the pharmacy, the new drug gets to the nurse. There's a lot of system issues involved in rapid titration that this solves that I don't think you can appreciate from this type of data. So I think there's value in it, but it's not the right thing for every patient. And again, we also have to figure out as a group, where do we want to target our QI efforts?
Okay. Thank you, David. It was an excellent talk. Please thank our sponsors this week, Allie Moon with Otsuka and Laura